Hello everyone, my name is Shonna Carlson. I'm going to be telling you about excoriation today, which is also known as skin picking disorder. Excoriation has a diagnostic code of 698.4. So what is excoriation disorder or skin picking disorder? So excoriation is basically a disorder where a patient pulls at the skin, scabs, lesions, or other parts of the body. This can be a cut that was existing already. It can be a cut that the patient creates. Also, some research says that people may pick at the skin on their lips. They may pick inside the nasal passage. A lot of times they'll pick on their scalp or on the bottom of their feet. And while most adults do occasionally pick their skin, I think we've all done that, this is to a level that it reaches a disorder and it causes a lot of harm, which we will talk about as we can continue throughout the presentation. So a little bit of history and general information. So prior to the DSM-5 being released, excoriation was actually not a disorder on its own. It was well known in medical literature and it was documented a lot, but it wasn't actually its own diagnosis. So the first time it was ever discussed that they know of in print was actually a young woman who was picking at her face in her acne, which is a common thing that people with excoriation disorder do. It was documented in 1898. And that was the first known time that anyone had recorded any information on it. So before the DSM-5 classified it as its own disorder, it would have been diagnosed under the impulse control disorder section of the DSM-4, along with other body-focused repetitive behavior disorders, which we'll talk about as well. So a common one that people hear about is trichotillomania, which is hair pulling disorder. And so the prevalence of excoriation has increased over the years, and with that increase in prevalence as well as increase in research for the DSM-5, people believe that it should be looked at as its own disorder because it was causing patients a great deal of harm and it was coming up a lot more. So that, combined with just the new research, led people within the DSM-5 creation to consider it its own disorder. So the diagnostic criteria are pretty straightforward for excoriation. So recurrent skin picking resulting in skin lesions. Again, this can be either from something that has happened to the person, like a mosquito bite or a pimple, or it can be something that people pick at that was healthy skin and then creates a cut. And there are repeated attempts to decrease or stop skin picking. So excoriation is pretty, not unique, but one of the main features of it is that the people who are doing it are aware of the fact that it is harmful. Not only is it harmful, it's also met with a great deal of shame a lot of times. So because there is that awareness, there have been repeated attempts to stop the skin picking, to stop whatever behavior they're doing in order to be healthier and also to be able to go out in public, which again we'll talk about later. It causes clinically significant distress or impairment, whether that be socially, occupationally, or in other important areas of functioning. So what that means is people may not be going out with their friends if they just picked at a scab on their arm that can be seen, or they may not know what to wear in certain situations because they have to cover up the scars that they have on their body, especially when it's dealing with the face. It may lead to less ambition at work, less people going out, all of that type of stuff. And it's not attributable to another disorder, like whether that be more medically based in the sense of like scabies, or if it's more psychological, like substance abuse or something like that. Whenever people are withdrawing from certain substances, they may pick at their skin. And so in this situation, that skin picking that the patient is experiencing is not a result of that. And it's not explained by another mental disorder. So this isn't happening as a result of a delusion or hallucination that you might see in a psychotic disorder or something like that. And again, this will also be talked about more in the differential diagnosis. So just some diagnostic features. I just wanted to highlight these because I think this is what we as clinicians will have to look out for. Because the only real thing that you would see from the diagnostic criteria are the skin picking, and that's what you would notice. These are things to look out for as the clinician. So again, it can occur all over the body, but it's commonly on the face, arms, and hands. People pick at healthy skin irregularities, lesions, pimples, calluses, scabs, anything like that. The issue with this is it creates a cycle, because as you pick at one thing, whether it be healthy skin or a cut, it scabs over, and then once there's a scab, the person may be more likely to pick at it. It can be triggered by boredom or anxiety, which I thought was very interesting, because I think people typically think of something like this as a result of stress and anxiety, and it is in a lot of situations, but it also is triggered by boredom, which is kind of more of the automatic way that's discussed. So a lot of times people will say they don't even realize that they're doing it. They're kind of in a trance, and then they look down and they see what they've done. When it's not really related to stress as much, they just kind of are doing it automatically and not even really making the choice. Again, I just highlighted that it's important to note that repeated attempts to stop or decrease skin picking have occurred, and they failed most likely. And again, it's causing impairment beyond what is normally seen. So, like I said, everyone may pick at their skin, some people may even make cuts, but it's not causing you the type of social impairment or occupational impairment that it is for someone who's suffering with excoriation disorder. So these are just some examples of what common types of impairment or distress are, which I talked about a little bit earlier, but people avoid social situations, they avoid going to work. A lot of times people put makeup over whatever they might be picking at, especially on the face. A lot of times when you're getting acne is also around the age when you start wearing makeup. And so for females, you will see an increased amount of excoriation and then covering it up with makeup as well, all around the same time. And some people have even said that they avoided mirrors because they didn't want to actually see the harm that they were causing all over their body. And another type of impairment and distress that comes with this specifically is you're creating open wounds that can lead to infection and scarring and other medical issues as a result. And so this is unique to this type of disorder, because with excoriation, you could be treating a client for something psychological, but you also have to recommend them to get medical treatment. And this could be because the cuts that they have caused have become infected. There have been cases where people needed surgery, and so it's just an important thing for people to be aware of. So course, prevalence, and prognosis. There's not as much information about excoriation disorder and skin picking disorder as a lot of other disorders. That is, I think, because it has just been classified as its own disorder, so now people are kind of, from what I saw, going back to look at the other research and seeing what was actually being talked about when they were talking about skin pulling and skin picking. So excoriation is said 1.4% of adults have it. That the people believe that's a little underreported, just because most things are underreported and because people might not realize that what they're doing is so harmful, because it is something that most people do. It can present at any age, but it commonly presents at the onset of puberty, and it frequently begins with different skin issues like acne. The sites that are picked are often changed by the person who is picking, so it's not necessarily the most common for someone to only pick their face or only pick their hands. It will generally change across their body as different things are being triggered, or different cuts appear, or different lesions appear, all that type of stuff. And it is usually chronic, so you will usually have it for your whole life, but it will kind of ebb and flow, so there will be increased periods of picking and decreased periods of picking. So those have been shown to correlate with how stressed you are, or just different life changes, or anything like that. So again, there haven't been many cultural considerations found with excoriation disorder. So 3/4 of individuals with excoriation are female. And again, that might be a little bit inaccurate, just because excoriation disorder is a disorder that is typically attached to appearance. And so because of the way our society is structured, females typically are the ones who would seek treatment for how they look, which is messed up on a whole bunch of different levels, but that is a concern that people have when seeing this percentage. Also, within cultures, appearance might be valued differently. So that's something for clinicians to be aware of, because depending on how much appearance is valued, their client might not talk about certain things or might not come in at all. So some current beliefs around excoriation disorder. Again, this is just important because it is a newer disorder that has been added to the DSM-5. There's new research being released all the time. So excoriation commonly begins before 10 or between the ages of 15 and 21. But again, it can happen at any time. And there's actually been research showing that there's a strong familial correlation for those with excoriation disorder. So basically those who have, like it says, clinically significant skin picking report having at least one family member who also picks at their skin. Again, that kind of gets into the conversation that we are so familiar with as psychology students, is nature versus nurture. So does that mean that there's a genetic implication, which again talks about right there? But is it more of a genetic implication, or is it that children see their parents doing it or other people in their life, and then they pick up the habit as well, and then becomes a part of their life? Again, so that was 28.3% to 43% with clinically significant skin picking report that someone in their family also picks at their skin. And so actually, interestingly enough, genetic factors accounted for around 40% of variance in skin picking in a twin study, which is really interesting. And then I just put this quote in here because I think it really sums up the new beliefs around excoriation disorder. So, individuals who skin pick often display elevated stress responses to normal stimuli, and skin picking appears to temporarily soothe such stress. So basically, it's not that those people who are skin picking their skin are in more stressful situations. It's just that a lot of times they might not be dealing with a normal level of stress in ways that we see as normal. So because of that, sometimes they might pick their skin as a result. I also think that this, and this is just me talking, but I feel like that one sentence may also talk or explain why other disorders are commonly diagnosed with excoriation disorder. Like in the slide, perfect. So comorbidity, a lot of times major depressive disorder, obsessive compulsive disorder, anxiety, trichotillomania, which is the hair pulling disorder, and substance abuse disorder are all linked to excoriation disorder. And this has actually been something that researchers are looking at because they believe that the numbers of people with excoriation disorder is actually higher, but it's being overlooked because of these disorders, because maybe with OCD, that skin picking has commonly been something that clinicians might consider a symptom of OCD. So skin picking is a symptom of OCD or anxiety, or it can be explained by these other disorders. So because of that, there hasn't been much looked into whether excoriation disorder is its own disorder in actual patients. That's something that clinicians need to be aware of now that it is its own disorder in the DSM-5. So differential diagnosis. I think it's really important for the clinician to remember, I think, two major things. One, that skin picking occurs on healthy skin, scabs, everything that I talked about previously, so when it's happening and where it's happening. And also that there's an awareness that it likely needs to stop, and there's some shame that comes along with it, because that is really unique to excoriation disorder, and that I think will rule out a lot of other disorders. So knowing that the patient has tried to stop and has failed can help the clinician narrow down what is causing the skin picking to occur. So with psychotic disorder, skin picking and excoriation disorder is not due to a delusion or a hallucination, like it is in psychotic disorder or any other disorder where delusions or hallucinations may be a common symptom. Also, other obsessive compulsive disorders may lead to skin picking like habits or look to them, in the sense that your hands may look like you have been picking at them, when in reality you might just be washing your hands a lot. Body dysmorphic disorder, skin picking, might occur in that because there is an overall sense of unhappiness with the person's specific appearance. And so when that is occurring, that if it's a result of someone not liking or hating their appearance, usually the skin picking is not excoriation disorder. And substance abuse disorder also, again, so sorry, I think my last video cut off because I apparently reached the limit. So anyway, as I was saying, with substance abuse disorder and people who are using certain drugs or alcohol when they withdraw, when they're suffering from withdrawals or they're using, it may lead to skin picking. So the clinician will have to be very intentional about making sure that substances are not the cause of skin picking, or not the motivation. So these are all different assessment tools, and I just linked them all because they're all very similar, but I think it would be important if you're going to be working with a population of people who are suffering from excoriation disorder to kind of pick which one you prefer. Basically, they're all self-assessments, or some of them are asked by the clinician, but either way, the patient is reporting how they feel or what they are in response to the question. So its typical questions are, how often do you feel the urge to pick? How often do you? How strong is the urge? What do you do to stop that? All this type of stuff. And how much time do you spend thinking about skin picking is also a really important question that I noticed in all of these, because even when someone is not picking their skin, they're still likely thinking about it. And so how often they're thinking about it, how long they're thinking about it for, is important information for the clinician to have when assessing how bad excoriation disorder might be, or whether or not the patient has it in the first place. So again, assessment information. Clinicians can use any scale they believe to be the most accurate, or which one they just prefer. It is important for clinicians to look for a preoccupation with picking, a difficulty in controlling picking, and distress resulting from skin picking. So all of these things are kind of strong indicators of excoriation disorder. The fixation is really on the skin picking. It's not something else that's causing the person to pick at their skin. Also, it is a newer disorder, so people might be less likely to have heard about it, or clinicians might be less likely to diagnose it on its own. Like I said earlier, a lot of times it will be overshadowed by a different disorder, and that might lead to an inaccurate form of treatment, or it might lead to a patient not getting everything that they need from a clinician, and then the skin picking might never be resolved, even if the other issue is resolved. So treatment. Of course, we've all heard of cognitive behavioral therapy, CBT. So similar to a lot of CBT treatment for excoriation disorder tries to restructure the dysfunctional thoughts that might trigger a patient to pick. So CBT is looking at what is causing the desire for the patient to pick at their skin, rather than just telling them to stop. Again, this can be done by clinicians asking really open-ended questions and kind of funneling the patient to see why and realize on their own what is causing them to pick at their skin, and also what treatments might be effective for them. So clinicians should develop a hypothesis, but still be open to what the patient is saying. We never want to force a diagnosis or force our own ideas onto a patient, but at the same time, it can be helpful to allow a patient to come to a conclusion on their own, as opposed to just telling them, you have this is what you have, this is why you're doing it, and everything like that. And they also should, as a part of CBT, encourage the clinician to maybe keep a log of every time they pick at their skin, every time they want to pick at their skin and don't, every time they are just thinking about it in general, and then what types of things are causing them to think about it or do it. So are they picking at their skin because they're just watching a movie and they're kind of zoned out, and it is more of that automatic way that we were talking about earlier? Or did something happen? Did they just move? Did they get a bad score on a test and they're feeling more stressed or more anxious? Is that what's driving them to pick at their skin or want to pick at their skin? And also, I think homework is important with any cognitive behavioral therapy. So have them think of what preventative measures could work, what activity replacement could work, what could this patient do to help them? Because at the end of the day, you need to find something that will stick And the only way to do that is to find something that the client is comfortable and excited about. Habit reversal training, kind of similar. So it teaches the client to recognize what they're doing, when they're about to do it, and why they're doing it. And so the awareness that clinicians and clients have, with that awareness, they can work together to create a response that's competing with the desire to skin pick. So every time they go to skin pick, maybe they take up knitting, they take up something else with their hands, they try to think of something else that they can do, braiding their hair if they have longer hair, something like that. That is a healthier habit to have, and it prevents the skin picking from occurring. And then additionally with that, there's a reward and punishment system that is created with the clinician and client. It begins when they are in a session together, and then eventually the client will continue this operant conditioning outside of treatment in response to their own behavior, and they'll begin to recognize when they're doing something good and when they're doing something bad. Just some treatment from medications. So if they're going to use medications, it's recommended that they also continue with a therapy of some sort. And selective serotonin ribitake inhibitors, SSRIs, again, which we're very familiar with, are commonly used. But more research about medications for excoriation disorder is definitely needed because it is a newer disorder. So for the case vignette, I'll just read it quickly because this is definitely longer than 15 minutes. Jessica is an 18-year-old college student. She has just started college 6 hours from home. She is struggling greatly for a multitude of reasons. Jessica shares a room with 2 other girls. They are very nice. However, Jessica feels like she has no time alone. This is particularly hard for her because she has picked her skin for as long as she can remember. Commonly, she peels massive chunks off the bottom of her feet, making it difficult for her to walk sometimes. She has used tweezers to do this. Additionally, Jessica loves to pop pimples and eventually picks at the scabs that form. She also itches and picks at her mosquito bites, causing scarring. She has tried to stop dozens of times and fails each time. She is extremely embarrassed, especially now that there are always people around to see her. She only wears long-sleeve shirts and when she has picked, and she rarely goes outside because her face is covered in cuts. Jessica reports picking when she is stressed, and even when she is bored. She says she does not even realize she is doing it sometimes. Jessica is seeking treatment because she does not know how to stop and she does not want to be seen by anyone. So, again, Jessica is kind of, as designed, the textbook example of what excoriation disorder looks like. She's presenting all the major diagnostic criteria. She's picking her skin regularly, which is causing harm all over her body. She's tried to stop and failed many times. She doesn't want to leave her room. So she can cover up unless she can cover up all the evidence of picking. So unless she can wear a long sleeve shirt, unless she can put makeup on, she doesn't want to leave. And it's causing her to miss out on social situations, going to class, everything like that. And she says she picks out of stress and boredom. So all of these facts make the diagnosis of excoriation disorder extremely likely. And again, I think Jessica is an example of excoriation disorder because she knows that what she's doing is wrong and she feels an intense amount of shame with it. Also, something interesting is that she mentioned she uses tweezers. That is common with a lot of people who have excoriation disorder. They may use tweezers, safety pins, a whole different bunch of tools when picking at their skin. So differential diagnosis. She doesn't seem to be doing the skin picking out of depression. She might be sad as a result of the skin picking, but it doesn't seem to be what's motivating her to skin pick. If anything, what's the skin picking is making her sad as opposed to the sadness making her skin pick. She also has not mentioned any substance use, and she doesn't have any other psychotic symptoms like delusions or hallucinations. Also, it doesn't seem like Jessica is suffering from a whole lot of OCD. It might accompany her skin picking, but it's not presenting in a way that seems to be the overall diagnosis. So just a bit of a conclusion and important things for clinicians to take away. Those with excoriation disorder will likely try to hide the physical signs of skin picking, so it's important for clinicians to listen to what their patients are saying and just be aware of what excoriation might look like besides physical symptoms. Even with that, those with skin picking disorder are likely to own their skin picking once they're asked about it. So because there is a strong amount of awareness with excoriation disorder, if a clinician asks if that is happening, a lot of times patients will own up to it and talk about it because they do have some shame and guilt around it. Excoriation disorder may need more than psychological treatment. So if you as a clinician are seeing major cuts and wounds and lesions on a patient's body, yes, you have a duty to them psychologically, but also if they need antibiotics, if they need surgery, if they need any other type of treatment for an infection or something, it is important that you recommend that and get them the care they need as well. More research is needed on excoriation disorder because it is so new, and clinicians should be educating themselves on excoriation as much as possible because more information is going to be coming out so rapidly. So that's my presentation. I'm sorry it's so long, but I hope you guys enjoy and learn a little bit about excoriation disorder. I have created a handout, and I tried to make it as short and sweet as possible so that way you guys can get the takeaways you need. I also recommended some readings, some basic information, but also some YouTube videos and a podcast. So definitely look out for those. Good luck and have a great rest of your semester.